So I'm Pete Basford, I'm one of the gastroenterologists here. You are all F2s, is that correct? Good. How many of you did F1 in St Richards? Yeah. And the other guys, where have you come from?
Worthing.
Brighton. Okay, so you've all been all within the trust, yeah. So we're supposed to cover the whole of acute gastroenterology in an hour, which is quite a task, which we're not going to be able to do. So we will mainly focus on upper GI bleeding. We'll cover acute severe colitis, hopefully as well, and then if there's time, I've got some liver type cases at the end. So if there's anything that doesn't make sense as you go along, or you've got any questions, or there's cases that you've seen that you weren't quite sure what to do with, then feel free to stop me as we go along. So yeah, that's what we're going to cover. So in terms of upper GI bleeding, these are the main areas that we're going to focus on. Okay. And just as a bit of background, so upper GI bleeding is defined as bleeding proximal to the ligament of Treitz, so duodenum upwards. It's fairly common, so between St Richards and Worthing we'd see something like 600 cases a year, so nearly a case per site most days. The tricky bit is that actually a lot of upper GI bleeding stops and starts spontaneously, so once someone starts to bleed they don't necessarily continue to bleed. So in terms of assessing the severity and how quickly they might need an endoscopy, it can be difficult because what you're seeing coming out doesn't necessarily fully reflect what's going on the inside. It's still got quite a high mortality, so the mortality in the last national audit was 10%. And if you develop an upper GI bleed as an inpatient, then your mortality is much higher. So in the last national audit it's 26% versus 7% if you present with your upper GI bleed. And that's mainly because if you're already an inpatient, you're probably in with other problems. You're more likely to be frail, elderly and comorbid. So to warn you, there are some cases that you're going to have to just work through. So just have a read of this scenario and then tell me what your thoughts are and what you think you would do if you were the ward cover SHO on call, or yes, ward cover SHO.
Do we have a previous hemoglobin?
Good question. Yes, and so when they came in, it was 125.
The urea?
13.
Yeah,
Previous
previous.
urea. Previous urea was 10.
Were these bloods done right away, or?
Yeah.
So I guess you want to approach in an A2E fashion,
Mm-hmm.
make sure that they're, obviously they're obs look okay, just on those ones there, but we're going to look at them, do a rectal exam.
You happy with all of their obs?
The rest rate's a bit high in there, we'll go with one option requirement, they've got a reason, so.
Yeah, so these obs are kind of okay. I'd say these are not quite okay. Yeah. Yeah, rectal exam, perfect, good.
When you look at the vomit, is it actually coffee?
Yeah, you've got to look at it. Can't take the HCA's word for it. What is it? Always want to see it. Yeah, good.
Drug history. She's had pain, she might take it.
Yeah, yeah. So what would you do at this point with her? So you've done all of that. What would you do?
She looked well from the end of the bed. I mean, she's got this pneumonia, but there's a nursing report kind of a massive change in how she looks.
Not really.
You look at the vomit first. Just
Yeah, it looks like coffee ground vomit.
Particularly excited.
What would you do? Beyond that, what would you do?
Make sure we have valid written saves.
Good. Yeah.
And the cannula, make sure she has PRN and SLS6, right?
Yeah.
all that stuff.
Good. Are you going to phone the gastroenterologist on call?
Probably not. It's
Not
not.
right now.
Yeah.
No. Okay.
What it would be originally, like 4 hours, is that all right? You know, just monitor for further vomiting.
Yeah, exactly. So the point here is that, you know, it only takes about 10 mils of blood to give you coffee ground vomiting, and the last thing this lady needs is rushing in and doing an endoscopy. You know, so people have dark vomit for loads of reasons, and I could put 20 others on this list, but the commonest that we see is they've got an infection. So coffee ground vomit to us normally means infection number one, possibly bowel obstruction or pancreatitis, or it could be DKA. You know, we've had someone with a ruptured AAA who presented with coffee ground vomiting. So, you know, it doesn't, you know, anyone with gastric stasis and any frail elderly person who's got a UTI or a pneumonia will tend to get a degree of gastric stasis. And if things are hanging around in your stomach, the lining of your stomach gets irritated, and there'll be a little bit of blood and oozing, and if they're sick, then they will often be sick because of the gastric stasis. It can look quite dark. What that does not mean is that they're having a significant GI bleed, and the last thing she needs is an endoscopy when she's, you know, already on a bit of oxygen, a bit of tachypneic. That can only make things worse for her. If they've got pain, that is not a feature of an upper GI bleed normally, so I'd be really worried that that's something else. And you're right, you know, you've said all the right things, so, you know, see if there's melena, and then just see what happens. You know, by all means, put a nil by mouth, give her some PPI, do the group and save, so that if it does turn out to be a bleed, which it could be, you know, you've done all the right things, but the last thing she needs is someone rushing in and sticking a scope down. What about this chap? What are your thoughts about him?
Slightly more worried than the last one.
Yeah. So, and why are you slightly more worried?
The drug history has aspirin, hemoglobin, like just generally sicker.
Sort of objective
Yeah,
evidence.
so
of
melena.
melena
Yeah.
as well.
Yeah.
Yeah. So he's got melena, and what do you think the chopped liver is? He's not eaten any liver. Yeah, so that's probably clot actually. So it does, certainly in terms of what he's putting out of both ends, it sounds more significant. He does look like he's got hypovolemic shock. And in terms of his bloods,
We don't know what his previous hemoglobin was, but
yeah, let's say it was normal.
it's not
Yeah.
super low, but
It's pretty low, you know, let's say it was 140 before.
yeah.
And bear in mind that he's in hypovolemic shock at the moment, so when you resuscitate him, that might be even lower. So how much blood do you think he's lost? Ballpark.
Quite a lot. 1.5 litres.
You have to, yeah. Yeah, so probably about 1.5 litres. If you go by the grades of shock, it's not an exact science, but I'm not going to grill you on this. I mean, you guys should know this, but if you go by the grades of shock, so he's grade 1, 2, 3, 4 hypovolemic shock. He is tachycardic, and he's got low blood pressure. So you know, probably 1,500 mils or so. So you've talked about A2E assessment. They do need 2 cannulae. I would say 80% of people that come down for a scope for a bleeding endoscopy have got 1 cannula, and it's normally pink. So that doesn't get done very well. We'll talk about resuscitation in a minute. I think most of these people don't need a catheter unless there's ongoing hemodynamic instability. Obviously they need bloods doing, they need a group and save. Remember to keep nil by mouth. If you don't tell the nurses to do that, someone might just stick a sandwich in front of them, and if no one's told the nurses and the patient, then sometimes that happens. So you give him some crystalloid, his numbers are looking better. What would you do with him next?
What was his platelets? I don't think it was up
They
there.
were at 115 and his INR was 1.2.
Don't you, if you give red cells, doesn't that increase portal pressure or something?
Who'd go for number 1, 2, 3, 4? Okay. So I think you could kind of argue for both of those, but probably 4 is the right answer here. So there's been quite a lot of research looking at what your transfusion trigger should be for people with acute upper gastrointestinal bleeding, and this is kind of the biggest trial to date, which was done in Spain, and nearly 900 patients, and their trigger for transfusing them was either when they dropped below 70 in I units or 90. So what they called a restrictive and a liberal transfusion strategy. And they did exclude very low risk patients, and they excluded those with massive hemorrhage. But what they found was that the restrictive strategy had a survival benefit. So the black line is the restrictive strategy, and there was a significant survival benefit. And the trial's not designed to look at these subgroups, but it did seem that particularly that applied to Child-Pugh A and B cirrhotics. But it may be that it did, there was an effect in these other groups, but the trial wasn't designed to look at those subgroups individually. But the things you just got to bear in mind with this trial is that these patients they were kind of at HDU level care, so they were having bloods every 8 hours for the first 48 hours, so quite intensive monitoring. So they were really keeping a close eye on things. And they all had an endoscopy within 6 hours. So in fact, most of what they did in terms of transfusion was kind of post-endoscopy. So I think you just have to bear that in mind. If someone comes in actively bleeding, what you don't want to do is get behind the curve in terms of keeping them topped up. But equally, this, did tell us that actually aiming for a haemoglobin above 100 isn't the right thing to do for these patients, and we should probably be aiming for 70 to 80 if they're otherwise fit and well. If they've got, say, ischemic heart disease or other cardiovascular comorbidities, probably 80 to 90, assuming they're cardiovascularly stable. If you've not reached cardiovascular stability, if they're still shocked, then that doesn't apply. Okay. Just in terms of the numbers you should be aiming for other bits and pieces, so platelets above 50 is okay. If their INR is above 1.4, then you should correct that normally with FFP. If their fibrinogen is less than 1, then they need cryo. And if they're bleeding heavily on, if they're bleeding significantly on warfarin, then vitamin K isn't going to work quickly enough. That'll take 8 to 12 hours to work, so you might need to give them PCC. And then if it's a DOAC and they're really shocked, then they might need one of the specific antidotes for a DOAC. All those are frighteningly expensive. And remember, most of the effect of DOAC wears off within a few hours. So it depends really on the degree of shock. And in GI bleed, the decision to give those drugs, I think, has to be authorised by the gastroenterologist on call. Some patients will be having massive hemorrhage, and that's where you should apply a massive transfusion protocol, because that means you get products released without too much discussion. You also get a porter to bring them to you. So we just move on to risk assessment. So we love risk scores for GI bleed. They're really they're the holy grail of gastroenterologists, because what we want to know is who can go home and come back for an endoscopy within a week or two, who can we stay in bed till the morning and nothing bad's going to happen to them, and who do we need to get up for in the middle of the night. The difficulty is that none of the scoring systems are perfect at predicting what's going to happen to patients. They're reasonably good, but they're not perfect. So the one with the best evidence pre-endoscopy is, I'm sure you'll be familiar with the Glasgow Blatchford score. It's on the back of the GI bleed request form, and that takes into account hemodynamic and blood parameters and a few other clinical parameters. So for our chap, he's got a score of 17, which actually is pretty high. And the Blatchford is where it's best. Actually, that should be 0 or 1. I need to update that. So if they've got a Blatchford of 0 or 1, which basically means if you fulfil those criteria there, then you can be managed as an outpatient. So there are big studies showing you won't come to harm or the patient won't come to harm if you let them home with some PPI and they come back for an OGD in the next week or so. So there is a protocol in A&E, certainly at St Richard's, that people with a Blatchford of 0 or 1 can be ambulated and go home. Where the scores are not so good is identifying who's at higher risk, as in who needs an endoscopy emergently, within the next few hours, or who can wait till the next day. And often, clearly, if they remain hemodynamically unstable and you're giving them plenty of fluid and blood products and they remain hypotensive, you just need to get on with it. You need to turn the taps off. But most people don't fall into that category. And if you achieve stability, then normally within 24 hours is adequate. The reason we use the Blatchford is it's the best predictor of poor outcome, so it's better than the other scores. So if someone comes in with a bleed, what are the most likely sources or causes?
Aggravated ulcer.
Yeah. Good.
Varices.
Varices. Yeah.
Esophagitis.
Yeah.
Varicose.
Yeah. Good. Bore halves, did you say?
Yeah.
Bore halves is a bit different. That's where where they've made a hole. So bleeding is less of an issue with that, but they may have mediastinal contamination. Yeah.
GI tumours. Can they bleed enough to?
Yeah, definitely. Yeah, so you've got I think most of the main ones actually, that's very good. So peptic ulcer disease is still number one. Sort of erosions, duodenitis, less exciting, we do see quite a bit of that. Esophagitis is quite a bit. Varices, less common, can be more spectacular. Actually, acute bleeding from malignancy is relatively rare. We do occasionally see it, but tends to be more chronic. And then there's a variety of sort of funny vascular malformations. But of course, when you see someone, you don't know which of these it's going to be. And in terms of how you manage them pre-endoscopy, the only real difference is whether you think it's likely to be a variceal bleed or not. Because if you don't think it's variceal, then we'll talk about the medical management in a minute, but it will slightly differ. Whereas if you think it's variceal, then you would treat them accordingly. And I think that the things you need to think about, obviously if they've got known varices and they come in with signs of a significant GI bleed, it's reasonable to think that's due to their varices. But if they're not known, but there's strong pointers in the history and examining them and their blood picture that they may have cirrhosis and portal hypertension, so if they've got ascites, they're jaundiced, they're a heavy drinker, it's reasonable to treat that as a variceal bleed until you know one way or the other. So I've just got a few examples. So what's that? Yeah, so that's a gastric ulcer just just below the incisura. And sometimes when we treat these things, particularly if we try and coagulate them, sometimes that little red spot in the middle is a vessel. Sometimes we can make things worse like that before we finally get control. Do you know what that is?
Cheese.
Sorry?
Looks like cheese.
Cheese. It does a bit on there. It's much more yellow on your screen. So this is the typical kind of inpatient that's been, I don't know, fractured and off, been in for 2 weeks.
Oh, no, I'm not going to.
In fact, I've just scoped a chap whose esophagus looked exactly like this. So this is just really horrific esophagitis. So typically this might be someone who's been in for a while and has been laid on their back and bathing their esophagus in gastric acid for a week or two. It might look like that. Gold star for anyone that gets that one.
Is that
Yes.
yeah, well, sorry.
Yeah, well done. So Duliphoy is a little aberrant arteriole, normally high in the lesser curve of the stomach, that can bleed quite spectacularly, but it tends to be intermittent. So often they'll get scoped and it will have stopped and there'll be absolutely nothing to see. Okay, so in terms of what you should do before they have their endoscopy, so should we give PPI or not? So our national guidelines still say do not give PPI, but the European guidelines say give high dose PPI. I think in this trust we'd be happy for you to give PPI pre-scope, okay? But it doesn't need to be a continuous infusion pre-scope, so just 40 milligrams BD. And it will work as well if you give it by mouth, but there'll probably be nil by mouth, so it's just safer to give it IV. If you think it's variceal, then you don't need to give PPI. Well, you can do, but if you think it's variceal, then, as you know, terlipressin and antibiotics. And then just the other things to think about. So if it's a high-risk patient and it's someone that you're lining up for a scope in the next few hours, then it's worth giving IV erythromycin or metoclopramide. There is randomised controlled trial evidence that erythromycin improves survival with GI bleeding. The reason is it's prokinetic and it will empty the stomach of blood so that when they have their endoscopy we'll get a better view of everything and be able to treat it more effectively. So that's proven in an RCT. Metoclopramide probably has the same effect, but it just hasn't got the studies to back that up. Probably have more luck getting nurses to give metoclopramide. And then tranexamic acid really only should be used if they're having a major hemorrhage. So the HALT-IT study of 8,000 patients showed no real benefit of tranexamic acid, but it excluded people who were having massive hemorrhage. So that's really the only time you need to give that. Why do our guidelines say don't give PPI? Well, the reason is that there isn't the trial data to suggest benefit in terms of transfusion, surgery, rebleed, mortality. What there is evidence for is if people have had PPI, there's a reduced need for endoscopic therapy. I think you can make an argument for it in terms of length of stay. I mean, with the bed state as it is, anything that, even if you're knocking half a day off length of stay, that probably pays for itself. So we're very happy for you to give PPI.
Would that also reduce just esophagitis? Because you going in with a scope and someone's laying back, you could get, I don't know, gastric juices going back up?
They tend to be nil by mouth anyway. There's usually very little gastric juices in there when we go down. I don't know that it would necessarily help with that. So we, ideally, if you can, you need to stabilise the patient before they have the scope. That's the order it should go in. But some patients can't be stabilised. The majority of patients will be scoped in endoscopy under sedation. But we would consider GA and doing it in theatre if it was felt, likely to be a variceal bleed, or the cirrhotics can become encephalopathic quite quickly. So lose their airway protection, or if there's ongoing haematemesis. I mean, for those patients, actually the risk of them getting a lungs full of blood is higher than the risk of bleeding in terms of what might kill them. And then in terms of what we would do, so that if it's non-variceal, so mainly ulcer bleeding, it will be a combination usually of adrenaline injection plus either clips or thermocoagulation, so some form of cautery. This is a cautery device that you can inject through as well. But we've also got sort of hemostatic powders now, which are quite helpful if the traditional methods haven't helped. So just to give you an example, so this is in the duodenum. There's an ulcer underlying this. You've got a little bit of clot lying over the top of it. So we normally go with adrenaline injection first, kind of around it. That normally will reduce the bleeding. You can see the duodenum sort of blanch there where they put adrenaline in. They're now attempting to put some clips on, but they're probably just clipping the clot, and you can't actually really see this is not a great example of how to treat a GI bleed. They put a few clips on, so this is one of the hemostatic powders. It's different to the one we use, but you can see it's a less precise method. It just comes out like cement powder, but they are quite effective, and that will stabilise most bleeding at least for 24 hours. In terms of varices, so most varices will be esophageal, and we band ligate them, so you have a little cap on the end of the endoscope with these bands around the outside. You suck the varix into the cap and then deploy the band, and it tamponades it. Gastric varices, a bit more scary, and the best method for treating them initially is in injecting superglue into them, which does work, but it is quite high stakes because you've got to get the timing right. You don't want to glue a needle into a varix and then have it stuck, and it can cause can embolize as well. So this is just an example of variceal bleeding. So normally go down, you can see here they haven't got the cap on, so you go down to establish where the bleeding is coming from. You can see some varices coming into view here, and then ideally you want to see exactly where the bleeding point is. You can see that spurting varix there at 12 o'clock. So we go down without the cap, work out where the bleeding's come from, then put the cap on the end once you've established it's variceal bleeding, suck the varix into the cap, you get this kind of red out, and then deploy the band. And very satisfying treating varices, as long as you can stop the bleeding. They've put 2 on by mistake there. If there's varicose bleeding that we can't control via the scope, then we can put down a Seng-Stark and Blakemore tube. So generally just the gastric balloon is inflated, and then some traction to apply pressure to the GOJ to prevent the blood flow up that's feeding the varices. That's only really a temporary measure, so that's just to get you to a repeat endoscopy or a TIPS if you can't control bleeding. So Seng-Starken is just to buy you time. It's not a definitive treatment. So post endoscopy, normally we've stopped the bleeding, but some people do re-bleed a small percentage, so you need to watch out for signs of that. But equally, some people will have melena ongoing for the next 24 hours. So it's really fall in haemoglobin, new hemodynamic instability that would make us think that they're re-bleeding. And then if they've had non-variceal bleed and we've needed to treat it, then generally we'd advise a PPI infusion for 72 hours. And in terms of terlipressin antibiotics, it's normally 3 to 5 days. And then we should have told you what to do if the patient rebleeds. So we will know whether we've done all we can endoscopically to treat it or not. So there should be in the report a recommendation that if the patient rebleeds, okay, there might be something else we can do endoscopically and we should redo that, or do they need interventional radiology or surgery or TIPS. So going back to the chap with the chopped liver, so he has an ulcer, it needs endoscopic treatment. Gets back to the ward, he's fine. Just to remind you, he'd had a previous coronary artery bypass graft and he's on aspirin. So which of those would you give him? Who would go for 1? 2? 3? 4? 5? What did you say, 5, James?
I was under the impression that, or at least someone said at some point, I might be wrong, that you don't even stop aspirin all the time. It's just the 75. You should keep on going.
Yeah.
I don't know why.
So the national guidelines now, the BSG care bundle is do not stop aspirin as long as they are on it for secondary prevention. So the reason for this, there's been a few studies again, but this is one of the main ones. So these guys in randomised patients who'd had peptic ulcer bleeding that had needed endoscopic therapy, who were on aspirin for secondary prevention. You can criticise this trial because I think 8 weeks feels a bit long for anyone really. I think a better trial would have been restart immediately versus 1 to 2 weeks. But anyway, they did bleed a bit more if you restarted the aspirin, but actually it wasn't significant. 10 times as many people died. So, and they died of vascular events. So if someone's on aspirin for good reason, then actually the guidelines are now don't stop it at all, or at least the endoscopist should be guiding you. We might, if it's a really big bleed, we might say 48 hours or 72 hours, but there's been a big shift. 10, 15 years ago, we'd probably say to hold off for a month. Now, maximum would be 48, 72 hours. Good. So I think that's any questions about GI bleeding? Do you know when to call us? Should you be calling us?
I'm in A&E at the moment, so I think I've only had one case of Maria Weistel with slight, but nothing. I think that was confirmed in an OGD, I think about a week or 2 prior to this patient. So I kind of was like, you're fine, you can go.
Yeah, I think we have said recently, I think it should be the registrar above that calls us. The majority of patients don't need scoping immediately. In fact, there is quite good evidence that patients do better if their endoscopy is done sort of 12 to 24 hours after they come in. If you rush in too early and you haven't resuscitated them or figured out exactly what's going on, there's some of them undoubted. Some of the people who do badly are the ones that aren't actually having a significant GI bleed, and you miss the fact that there's other things going on and they're septic. So there will be the occasional case where it needs to be urgent, but actually most patients can wait till the next morning. Okay, so we should have time just to cover UC at least. So another case. So I've slightly given the game away by giving the topic, but what do you think about this chap?
Since
severe if his bowels are open 20 times a day.
Yeah, and so he's normally fit and well. He's got no known history. What are your thoughts about what's going on with him, and what would you do? Let's say it's 6 p.m. on a Friday evening.
I don't know if this completely sounds upper GI. This sounds more like what bloody stools are they? Are like frank bloody, or are they?
It's kind of diarrhea with loose diarrhea.
Yeah.
Well, not high volume, but loose bowel motions with blood. It's not frank blood.
I guess because he's a prisoner young guy, he's a chef.
Mm.
I guess the curiosity is like slightly too long. My first thought would be like some kind of infective.
2 months though.
But yeah, 2 months is obviously long.
Yeah. What would you want to know? What sort of things would you want to ask him?
Smoking, he's a chef, probably smokes.
Yeah.
Alcohol.
Alcohol. Yeah. Anything else?
Previous episodes, there's
Yeah.
mucus in the bowels, if he has any like eye or joint symptoms and stuff.
Yeah. Good.
Family history.
Family history. Yeah. Anything else? Apart from where he works. So you might want to know if anyone else has been unwell. Probably more relevant if it's a shorter duration. I definitely want to know if he'd been overseas, because most infective causes of this type of presentation in the UK would be self-limiting, but if he's been somewhere more unusual, you might get something that would persist for longer. You definitely want to know about family history. Yeah, these are bonus marks for these kind of symptoms. And then on examination, obviously you do an A to E assessment. Might want to look for peripheral stigmata of IBD. Check that he's not got peritonism, distension, masses, unusual in a 27-year-old. So what's your differential for him?
I think it's probably ulcerative colitis, but
Mhm.
it could also be Crohn's. This is more unlikely, but he's 27, he works in the food industry and he has celiac. And you said foreign travel.
Yeah. What?
You wouldn't expect blood in celiac, but I guess
No.
if he
Yeah. So
if he gets to that point.
so the loose bowel motions and maybe a bit of weight loss could be celiac, but blood would be very atypical. It is not consistent with celiac disease. Okay, so we've got UC or Crohn's. Could be infection, less likely. 2 months. Anything else?
Could be multiple things, like you could have hemorrhoids that are bleeding a bit, but he's also got he's also got sort of loose stools on top of that.
Good. So this, I mean, the point is that this is ulcerative colitis until proven otherwise. You know, I think with that duration of history, if he came in with a 1-week history or 3-day history, it's much more likely to be infection. But when it's beyond 2 weeks, you know, you've got to be thinking, is this first presentation of IBD? But keep these other things in mind. I mean, obviously, you would definitely send a stool culture and a C. diff toxin. Young people do get bowel cancer, but pretty unlikely in a 27-year-old. And you know, this is acute severe UC until proven otherwise, and what makes it acute severe, which is the severest form of UC, is that he's got 6 or more bloody stools a day, and then you only need one of these, and that can be CRP or ESR. And I think if we go back, did I give you his? No, I haven't given you those. Okay. Yeah. So you need one of these, assuming he meets one of those criteria. The more of those you have, the more likely you are to have a bad outcome. So what would you what would you do with him? You think this might be first presentation of ulcerative colitis? You think it might be severe ulcerative colitis? What would you do in terms of investigations and then management?
Calprotectin. Flexi-sig.
Yeah, is Calpro going to help you?
Probably not by that question.
If someone's this sick, Calpro isn't going to. Yeah, they need a scope, don't they? Which Calpro is more like it's more like a D-dimer. If it's negative, you know, in a patient where you're not sure whether they've got IBS or IBD as an outpatient, it's useful to rule out IBD. It's also useful disease monitoring for people with established IBD. But if someone's this unwell, he's going to need a flexible sigmoidoscopy. Yeah. Okay. What else? What about before the sigmoidoscopy? It's Friday evening, remember?
This is hemoglobin okay.
Yeah. So you're going to do some bloods. What bloods would you do? Say full blood count.
Using these correlation.
Yeah. Anything else?
You do like bone profile magnesium to make sure it doesn't have any electrolyte non-related.
You could do, yeah. I wouldn't routinely, but I suppose if his potassium was low, you might want to. Yeah. Anything else?
If he was that unwell, would you do tumour markers now?
You should get that to albumin.
Yeah. So you get that as part of your LFTs. So far we've got bloods, flexi-sig. Anything else?
Still culture.
Stool culture. Yeah.
Abdominal film.
Yeah. Good. And then, what about management? So what do you?
Steroids.
So you request a flexi and they say, well, that's probably not going to be till Monday. So steroids, you're going to go straight in and give them steroids.
Would you withhold them until the flexi sick, but you'd wait for ages and he's having 3 stools a day? It's not very kind, but it's probably.
What would you do?
If you were having a diet,
6 p.m. Friday.
it's called a med crash. That's so nerve.
Give them or not give them? Who'd give steroids?
Yeah, probably give them.
Who wouldn't? Okay. And if you're going to give them, what are you going to give?
IDH course.
Okay. Yep. All right. And what else? What else are you going to do?
Like a rectal salazine. That's severe, so you probably bypass that.
Or
Yeah. Mesalazine's not going to. If this is UC, mesalazine's not going to. Well, rectal mesalazine's not going to touch it. What else? You're giving steroids. What are you going to? What should you always do?
PPI cover.
Now PPI is a bit debatable, but yeah, I'll give you that. It's falling out of favour because it messes up your microbiome. But what must you give with the steroids? And if you don't think of it now, you'll forget it.
For bone protection.
So it's got to have bone protection. Anything else?
Analgesia.
Yeah. Yeah. What analgesia would you give if he is uncomfortable? What would you give?
Give some paracetamol when it's sleep.
Yeah.
And then leave that for the weekend team to sort.
Yeah. Anything else? What else are you going to put on his drug chart?
can you give hyoscine, or is that contraindicated because of, I mean, once you've done the abdominal x-ray, they don't have. So it's kind of,
Yeah, we tend to avoid it because it's thought to increase the risk of toxic megacolon, as are opiates. One thing.
Make sure he has VT prophylaxis.
Yes, must have VT prophylaxis. Okay, so so you do. I didn't ask you this, but you would do a flexi rather than a colonoscopy. If he has got severe UC, you don't want to be trying to do a full colonoscopy. It's too dangerous. So a flexi sig will give you the diagnosis. He does need a plain abdo film. The last thing you'll get of all of this is probably the stool chart, but he does need a stool chart because that's how we know whether he's getting better or not. And then he needs QDS hydrocortisone. These patients must have VT prophylaxis. They're really high risk. Their risk of VT is sort of 4 to 5 fold that of sort of age-match controls. Often they don't need fluids and electrolytes, you just have to judge that on your clinical assessment, but most patients with UC, assuming that's what it is, aren't volume deplete. Low residue diet will help with the symptoms. We try and avoid these medications, and they need to go to a gastro ward, and really they need a side room with their own toilet. So this is a nice normal colon. This might be what his colon would look like. So very inflamed, lots of ulcers, sort of covered by slough. And the reason you do an abdo film is looking for toxic megacolons. If the transverse colon is more than 5.5 centimetres in diameter, that is a very worrying sign, and they are probably not going to respond to medical therapy, and they probably just need to have an operation before they get really sick. What about any bits you've not mentioned in terms of what we need to do at this stage? So just think beyond the first 6, 12 hours. What might happen to him? What are we going to be thinking about?
Maintain remission.
Well, we haven't got him into remission yet.
Just keep milk on mouth.
Not at the moment. If he was deteriorating, or he developed a lot of pain, or he had a toxic megacolon, then yes.
Do you want to go in like maintenance fluids or some maintenance dextrose or something, because then like he's maybe not eating?
He should be able to maintain hydration. Well, what's going to happen to him over the first 2 to 3 days? Okay, so he's got severe colitis. There is a fairly strong chance that he might need rescue therapy, so you need to plan ahead for that. So he needs a pre-biologic screen, which is the top 2 lines. If you happen to work in a hospital where they give cyclosporin, which not many places in the UK do anymore, they'd want magnesium and cholesterol. But if we're thinking about that he might need infliximab, then he'd need all of those blood sending. So really, if he's this bad, you want to be sending them up front, just so it's done. And then if there's any, if he's looking severe and he's maybe not responding, you might want to get the surgeons involved. And you want to be thinking about, okay, this is the colectomy rate without rescue therapy, so actually it's much better than that. But the more of these criteria he meets, the higher the risk of him either needing a colectomy or rescue therapy. And also the CRP at diagnosis and how low the albumin is a good predictor of bad outcomes. So this is kind of how we think about these patients. So they would, you give them hydrocortisone, and we normally then assess the response at 72 hours. And you look at them globally, but there's fairly good criteria called the Oxford criteria, where if at 72 hours they're still going more than 8 times a day, or in 24 hours, or 3 to 8 times a day, and their CRP's above 45, then if you just plough on with steroids and hope for the best, there's an 85% chance that they'll have a colectomy. So at that point, at 72 hours, if they're meeting one of these 2 criteria, you need to do something different. And then the do something different. So if they respond, if they CRP is less than 45 and their stool frequencies come down, then we normally give another 48 hours of IV. A couple of other criteria that you have to meet then. I don't want to put it all in, it gets a bit complicated, and then you'd switch them to oral steroids. But if they're non-responders, then in this hospital you could either go straight to surgery, but most patients would choose to have rescue medical therapy, which here is infliximab, But cyclosporin, in terms of trial data, is equally good. It's just a bit more messy to give, and most places don't use it. And then you would give a few days to see whether they respond to infliximab. So normally 3 to 5 days. And if they respond, you'd continue with it. If they don't, then really they need an operation at that point. Cyclosporin, they'd then go on to oral cyclosporin and then azathioprine. But the point being that you can't kind of sit around for days and weeks seeing whether these patients got better. Actually, if you do that and just cross your fingers, then you end up with someone who's been in hospital for 10 to 14 days, bathed in steroids. Their Alvin's now 18, and they do badly in terms of surgery. So each day that goes by, if someone needs surgery, each day that goes by beforehand, their post-operative complication rate goes up by about 7%. So you do need to make these, and obviously these decisions should be made by a consultant gastroenterologist with input from colorectal surgery as well. But it's just important for you guys understanding kind of how we're thinking about and how we're managing them. In terms of so do people still die of colitis? They do, but thankfully pretty rarely now. So it should be less than 1% mortality. They should all see an IBD nurse during this admission, which we don't always achieve, but we aim to. This is from the national audit. Even if they've got known IBD, you should always check them for C. diff, because patients with IBD have got a higher risk of getting C. diff. And what you don't want to do is be giving infliximab to someone who's actually got an infection. And we're pretty good at prescribing VTE prophylaxis, although in our local audit we were still not perfect when we audited this. Yeah, okay, let's move on. So, yeah, I think it's just important to recognise it. And in terms of, say he had a 2-week duration of symptoms, and it's Friday evening, you haven't got the stool culture results back, would you still give him steroids? He's had a fortnight of symptoms, and his CRP is 150.
Yes.
Yes. Is everyone yes?
Not sure.
Why wouldn't you?
In case you're still thinking it's infective cause, and you actually just damage his.
Yeah, so it could be. So it could be that he's had Campylobacter and it's just taking a bit of time to settle. Will he do any worse with steroids if it's Campylobacter? So say you give him steroids for the whole weekend and his Campylobacter, a stool culture's been sent and it comes back positive on Monday, will you have done him any harm?
No. Is it much longer?
Yeah, so the evidence would suggest if they have a brief duration of steroids and then come back with a positive stool culture, that actually patients don't do any worse. So you won't make things worse if it does turn out to be infection. But if you've left his UC, severe UC, untreated, then that could well do worse. I think if it's a 2, 3, 4 day history, then I'd hold off. That's much more. If it's an acute onset, a bit of rigors, crampy abdo pain, I would dive in with steroids. I think if it's less than a week, assume infection, wait for the stool cultures. Okay. I think we'll have to stop there. I've got to go. Any questions about either of those?